We're just thanks everyone for joining us. We're going to get going imminently, just giving time for everyone to connect their audio, etc. Wonderful to see so many people joining us this afternoon for this important forum. Great. So I might get started then, as we have more people joining us, but we don't have a lot of time and we have so much to talk about. So good afternoon, everybody. Before we do start, I would like to acknowledge that we're all on Aboriginal lands joining the seminar this afternoon. I'm currently on the lands of the Wurundjeri people of the Kulin Nation, and I'd like to acknowledge their elders, past, present and emerging, and particularly a warm welcome to any First Nations peoples joining us this afternoon. My name is Ben Cowie. I'm the Director of the WHO Collaborating Centre for Viral Hepatitis, and it's my great pleasure and my honour, in fact, to be able to help facilitate this session this afternoon, the Perinatal Research Seminar, focusing on the really important issue of providing services to women and to their infants for the protection against some really priority communicable diseases. So we will get going. If I could just make a few housekeeping points initially. So if people who are not speaking could keep themselves muted, please. You are very welcome to put your questions for speakers or for the panel at the end in the chat, or during Q&A sessions, very happy for you to unmute and raise your hand, be it digital or real. Please do be advised that this seminar is being recorded this afternoon for the purposes of being able to share with others down the track. So please do let us know if you've got any concerns about that. So just by way of very brief introduction, this perinatal research project was funded by the Victorian Government Department of Health and really aimed to map the delivery of interventions around vaccine preventable infections in pregnancy, specifically influenza, pertussis, and hepatitis B, prevention of mother-to-child transmission. The research project itself has three components. The first being a more comprehensive data linkage and data analysis project to really look at the to provide an accurate estimate of the uptake of interventions to prevent mother-to-child transmission of hepatitis B. The system mapping aspect of the project was the second element, and really is intended to explore how mothers with experience the service delivery, so the service delivery aspects for hepatitis B, influenza and pertussis vaccination during pregnancy. And finally, and really importantly, looking at the community lived experience to explore how mothers with chronic hepatitis B both understand and experience service delivery in the context of chronic hepatitis B. Important to acknowledge that both the community and system mapping elements of this research were conducted in partnership with Liverwell and the Burnett Institute, and we've got representatives of both those organisations on our panel this afternoon. So the lead researchers who are here to present today are Nafisa Youssef and Nicole Allard, both from the WHO Collaborating Centre for Viral Hepatitis at the Doherty Institute. They'll initially be presenting the findings of the research and the associated recommendations from the project team. Then we'll go to the panel, which has a broad range of speakers and panelists, both from the Department of Health, the researchers themselves, and again, bringing forward lived experience and the associated aspects of the qualitative research. Before we get going though, if I could possibly, and with great gratitude for her being here today, introduce May Mack, who's going to give us her lived experience as a woman living with hepatitis B. May has a Chinese background, was born in Vietnam. She's a mother of 2 children and was diagnosed with hepatitis B in the 1990s here in Australia. May was also part of the Perinatal Community Advisory Group that co-designed this research. So May, thank you for being here, and over to you. Thank you.
Thank you.
Your audio is a little hard to hear, May, I think.
Is it better now?
Yes, that is better. Thank you.
Oh, good. That's better now?
Yes, it's great.
Okay, thank you. Sorry about that. So yeah, thank you for the introduction, Dr. Ben, and thank you for the welcoming. I'll go straight into the diagnosis. So in the 90s, I was diagnosed with hepatitis B. The process for testing was simple. It was through a blood test that I did at my GP. But at the time, they said to me, the doctor said to me that I was the carrier of the hepatitis B, which is not the same as these days. You either have hepatitis B or you don't. So at the time, I did not think much of it. It did not seem very serious to me. I went for some checks with my doctors, and that was all. Around roughly 12 years ago, after a blood test at the GP, again, that my hepatitis B viral load was high. And so then my doctor, my GP, referred me to a hospital to see a hepatitis specialist. So that's where I began my journey on the treatment. So not treatment as such, I didn't have to be like on medication, but from then on, I have to have I have a regular checks every 6 months. Like some others, I do not take regular medical treatment to manage my viral hepatitis B. Other people have to take lifelong medication to manage their health, their liver health. So two things I have learned from these was that advice by my specialist doctor was not to eat fatty food, so just lean meat, and then importantly that I must not drink alcohol. So that's a downfall, right, for me. No red wine and things celebration. But yeah, so that was that, and that I have to make sure that I continue to attend my regular GP appointment, but actually for me it's to my specialist appointment to monitor my liver health. So down to recent times with COVID last year and this year, I have not, missed my appointments. So I still went last year and this year to the scans, ultrasound, fibrosis appointment, and blood test, and I have telehealth. So I have telehealth appointment with my specialist. So that was all being taken care of. For me, it was quite a smooth journey. I'm blessed. And, yeah. So I think I'm blessed that in Australia, we have a good healthcare system for patients like myself. So all I have to do is just watch what I eat and attend to my appointments. And and I'm an advocate of, sharing my story and encourage others. In my family, we are open to talking about our liver health. And my dad would say, or my sister, or siblings, would alert to say, how's the checks, how's everything? And I said, yeah, I went, everything's fine, and things like that. And one of the siblings said, who was a scientist, oh, the good result. I don't know how to read much about the result, but it's good to get a record, to see what's up. But that's my story, everybody. I'm glad to share it. So thank you, Dr. Ben, and everyone. Thanks for your time.
Thank you so much, May. That's such a wonderful introduction. And before you go, and if you're comfortable doing so, and if it's not your personal experience, then the experience of other mothers who have hepatitis B, I wonder if you could particularly reflect on hepatitis B as a mother. And you've said that the health system looks after you well. Would you have any recommendations for us as health practitioners, as community members, as advocates, as government representatives around particularly hepatitis B and mothers? Or if you prefer, we can leave it to the Q&A, the panel at the end.
Yeah, we can leave it till then. I'll stay till the end. I'm excited about this and working with Navisa on the surveys and that for past, how long was it, Navisa, you and Nayland and Nicole? It was exciting news to know that we implemented, some good news for moms in the birth ward. Remember back, I don't remember. I have to maybe look at the book, the baby book, the yellow book, to see a record, because I don't have a memory. I believe they did vaccine my kids, baby, when they were born. But from memory, I don't remember the doctors or, focusing on too much. I'm asthmatic, and I asked about, first or second child about asthmatic, but doctor, will my baby have asthma, because I'm an asthmatic mom or patient, and they said in gene, but nothing about liver. And then I already had liver problem, hepatitis B then. So not much talking there while I was giving birth there, after or before or after. They say, yeah, your baby's vaccinated. Okay, after this May, you will be so nothing much. So it would be wonderful to have something there for the moms, and for us moms giving birth, and get an understanding of more what it is, how we're going to look after our health going forward after giving birth. Are the babies okay? Even though the vaccine, are they okay? And things like this. It would be wonderful.
Well, that's wonderful, and I'm sure we can benefit from your experience and your perspectives in the panel at the end. Thank you so much.
Thank you.
Thank you. And it's now my great pleasure, going from May's words and testimony with lived experience, to go to the community aspects of the study. And if I could possibly introduce my colleague, Nafisa Youssef, who's a researcher with us at the Collaborating Centre at the Doherty Institute. She has a background in community engagement and research. Nafisa is ferociously passionate about health equity and improving the lives of people affected by hepatitis B. So Nafisa, over to you. Thank you. Sorry, you're muted, dude. Sorry.
Of course I am. Thanks everyone, and thanks, May, for sharing your incredible story. You've been such a advocate and just a really great person to work with through the community advisory group. So thank you so much for all your contributions. So today I'm quickly going to talk about the community study. And so for those of you who might not seen this, and I do acknowledge that some of you have seen this presentation before, so please bear with us. So just to give you a bit of a background, there are about 800 women with chronic hepatitis B who give birth every year here in Victoria. And there's been evidence of a local mother-child transmission. And children who are exposed to hepatitis B perinatally have a higher risk of developing chronic hepatitis B as adults without interventions. And mother-child transmission is a key priority both here in Australia and also globally, and part of the trouble elimination both here, again, in the national strategies and also overseas. So just to give you a bit of background in terms of methods, we were really interested in mothers' lived experience. So we were kind of wondering and investigating, service delivery aspects, what information was given to women, how they understood that information, most importantly, and also their child's vaccination of hepatitis B. So as I said earlier, this study was co-designed with mothers with hepatitis B, and I would really like to acknowledge that. Our inclusion criteria was women with hepatitis B who have given birth in Victoria in the last 10 years and who were the age of 18 and over. And we recruited women through purposive and snowballing sampling, that's just through networking and word of mouth. And we conducted interviews through semi-structured interviews and also analysed through thematic analysis using in vivo. So the results were, we interviewed 16 participants overall, between 18 to 59. 11 were born in Asia and 5 born in the African region. 7 of the women required an interpreter, so overall speaking over 10 languages. 12 of the women had only primary and or secondary education. And the key themes that were identified in the study were being diagnosed, understanding of hepatitis B, understanding of vaccination and transmission, navigating the healthcare system, and hepatitis B fear and concerns. And I'll be going through some of these themes with some quotes, but also please keep in mind what I'm presenting today is a snapshot of the interviews. We have so much data and quotes that we couldn't include for the purpose of the time. So firstly, being diagnosed, women were diagnosed in a very complex time of their life, which was, either through migration and or when they were coming to Australia, or through giving birth. So some women had said, as Sam said here, when I gave birth, that's when I found that I have hepatitis B, and that she was really shocked that she was diagnosed. And women also reported that they were not given much information about hepatitis B. As Arif here mentions that she wasn't told much about hepatitis B, the doctor just requested some test results. So that discussion about hepatitis B didn't occur for most women. Understanding of hepatitis B. So women had low understanding of hepatitis B. So even women who were diagnosed, 10 years ago or even 20 years ago, their understanding of their condition varied. So some women had a little bit of understanding of hepatitis B, and some didn't understand much about what hepatitis B was all about. So for example, Fatu here says it's a disease that progresses in time and that there's no medication, but there's no treatment. And this has been a woman who's been living with hepatitis B for a long time. Yuri also talks about here that, it's like a carrier, as May mentioned in her story, that women are being provided with incorrect information about hepatitis B. Sorry, I think I'm having some technical issues here. My slides are not going smoothly, but let me know if you can't see the slides that I'm going through. So
we can see them, Nafisa. They're working fine.
Oh, great. Okay, it's just me then. That's fine. I'm sorry, just bear with me for a second. I've lost a slide.
It was off before, but then it's on. So it's all good, Nafisa.
Oh, great. Yeah, excellent. Yeah. My internet is really slow today, so I apologize. Okay. So just moving on to understanding of vaccination and transmission. So this again varied across women, but most women didn't really understand the purpose of the vaccination. So as Yura says here, it builds the immune system against hepatitis B, I believe. But some women didn't really understand what that all means. So there were still, concerns of mother-to-child transmission, about what it means that their child is vaccinated at all against hepatitis B. And Fatu talks about here, there's a chance of me passing it to my child. And she actually misunderstood the heel prick. You would know if you work in healthcare system or you've had a child in Victoria, the standardized heel prick that I guess detects other but rare medical conditions, not hepatitis B, but she misunderstood that to be hepatitis B testing. So when I talked about hepatitis B and testing, that was really confusing for her because she didn't understand what she's had, I guess, in terms of vaccination, what vaccination her child had, or what she didn't have, because she wasn't sure that these vaccinations was hepatitis B. And her understanding was that her child was actually tested for tested for hepatitis B. But obviously that wasn't the case. It was just the heel prick testing. So most women also struggle to understand the information provided to healthcare providers in terms of breastfeeding. So Amala here talks about that, she was told not to breastfeed her child for the first 24 hours. But we know that obviously, it is safe to breastfeed even, if the mother has hepatitis B. So women are being provided with unclear and actually quite wrong information about breastfeeding and hepatitis B. Navigating the healthcare system, again, we're talking about, communities that often either don't speak English well or don't speak English at all. And the complexity of navigating the healthcare system really came through some of the interviews. So Fatima here says that, the healthcare providers didn't really get involved in my care. They knew that I have hepatitis B, it's in my history. They do the blood test at each pregnancy, but they don't provide any information. And again, that was a common theme coming from the interviews, that, most of the focus was actually on the baby and not so much the mother. There was also, the understanding really varied of hepatitis B. Amal here says that sometimes I don't understand what they say, even with an interpreter. I think sometimes the assumption is get someone an interpreter and they're going to understand. However, this has come through the interviews that information really needs to be given in a way that makes sense, in a plain language, in a way that makes sense for the woman in an easy language, and women can navigate through that. There was also challenges for mothers who wanted to test their child after the vaccination. So we know that through the recommendations for hepatitis B, children are recommended to get tested who are born to mothers with hepatitis B. But most women weren't aware of that recommendation. And the few that were aware, some of them faced some challenges. So Rosa here she tried 2 or 3 times to get her child tested for hepatitis B, but she was unable to because there weren't enough nurses at the pathology center. And she was told repeatedly to either come back or to go to the nearest hospital. And of course she didn't, because she said, it's about taking time off, it's, sort of rescheduling everything, and that makes it extra challenging. So mother-to-child transmission was a huge concern for mothers with hepatitis B in the interviews. And as Thoda talks about here, hepatitis B is not a standalone issue for her. It's something that is in her, family. It wasn't something that was new to her. She had it, her husband also has it. And she was really concerned about not passing that on to her child, even though her child was vaccinated against hepatitis B. So most women, even though if their child was vaccinated, they were still very concerned about not sharing toothbrushes or utensils, or they were worried about hugging their child, kissing their child. And as I mentioned earlier, we're talking about women who were diagnosed, 10, 20 years ago. So, carrying that burden really came through. And again, San was really concerned about mother-child transmission, and she said her son wasn't bathed before the vaccination, and she thought if her child was vaccinated, the needle will carry some fluids, and therefore her child will have hepatitis B. So there's huge concerns about mother-child transmission. And again, coming back to the comment around hepatitis B being in the family, within the community, it's not something that's new to a lot of people. As Fatu talks about here, she's seen a lot of people die of this disease in her close friends and families. And that's why she's really worried. And again, it really comes down to this mental health load for people, that it's not just about themselves, but it's about their wider community. So in short, hepatitis B diagnosis for women was really complex, being diagnosed at a critical time of, migration or perinatal journey. There was little to no formal hepatitis B information provided to women, particularly during diagnosis. It was sort of rushed through, or it was either they weren't given the information that in a way that they understood. There was also a poor understanding of hepatitis B, particularly the protection of the vaccination. And there were concerns about passing hepatitis B to their child, and also liver cancer broadly. There was poor social and emotional support for mothers, particularly during diagnosis and through postnatally. There was also no relevant hepatitis B information around pregnancy for women. I'll stop there for any questions before we move on to linkage.
Nafisa, if anyone does have a really quick point they'd like to make or a question for Nafisa now, please do feel free to do so. If you put up your hand or type in the chat. And I'll give a few seconds for people to get that question through. Otherwise, Nafisa, in the interest of time, what we may do is hold over. I've certainly got several questions that have risen for me, but we might hold them over to the panel if there's nothing burning for people, if that's okay with you. Great. So thank you so much, Nafisa. Really important findings, and I'm sure they will stimulate a lot of discussion. What we might do now, as Nafisa has just mentioned, is turn to the data linkage and analysis study aspect of this broader research project. It's my pleasure to introduce Dr. Nicole Allard, who's a postdoctoral researcher and medical epidemiologist with us at the WHO Collaborating Centre for Viral Hepatitis. She's also a general practitioner with a special interest in refugee health and hepatitis B in primary care. So over to you, Nicole. Thank you.
Thanks, Ben, and thanks, Nafisa, for leading off with the importance of lived experience. So now we get to a big data set, and I think a lot of what Nafisa is talking about is about the reflection of experience within the numbers. So just very briefly, the methodology was that we linked, and sorry, I should say we. When I say we, this is the work of Anna Deng and Nicole Ramiro and Stacey Rowe, who's also on this call. So I get the honour of presenting this, but I feel like a bit of imposter syndrome there as well. So we linked data sets, including the Victorian Perinatal Data Collection Set, which I will now refer to as the VPDC, FES, which is the notification system, the Victorian Admitted Data Set, and also the Australian Immunisation Register. And these are births from 2009 until 2017. And really what we were looking at is identifying pregnant women and also pregnant women with hepatitis B. So that was the kind of the background to the linkage. Next slide, Nafisa, thanks. So this is just a bit of a snapshot. There was nearly 700,000 mother-infant pairs identified, and there was 3,518 women who were diagnosed with hepatitis B. So it was about a little under 1%, 0.76% of infants born. Now, we had the birthing events, which are obviously they're documented in the VPDC, but they're also in the admitted admissions data as well. And we also had linkage to air. So what we're going to do, I mean, there's been quite a lot written already of this study. So what we really are going to do is just look, especially at hepatitis B birth dose uptake. And the important thing to understand as a background is that prior to 2017, timely birth dose, so birth dose should be given within 24 hours to be effective, and timely birth dose was recorded in the VPDC as less than 7 days. So it's only in 2017 where there was a change in the data collection to reflect what really is the best way to record hepatitis B birth dose. So if we're looking at 2017, we can see that this is timely birth dose within 24 hours, that we've actually got birth dose uptake of around 93% in a timely way in the general population. But we've got quite a few women who aren't getting it in a timely way. So actually, sorry, 85%. And then we've got 0 to 7 days. And then we've got not at all or not recorded. So we're actually a little bit undercooked in terms of our delivery to birth dose, the population. Now, if we look at on the right-hand side, these are women, infants born to women who have hepatitis B. And really, what are we aiming for here? Well, we're really aiming for 100%, because what we want is those infants who are at highest risk of hepatitis B to be getting timely birth dose. And what we can see from this data is that 1 in 20 in 2017 were not getting timely birth dose. Next slide. And when we look at by hospital in 2017, so again, specifically narrowing down on 2017 because that was when the data recording changed. And on the right-hand side of the scale, red and darker red represents larger hospitals and blue are smaller hospitals. But what we've got is that birth dose uptake for the general population is quite varied. And so we have areas and some large birthing hospitals, for example, Hospital 18, which is a reasonably large birthing hospital with a comparatively low uptake of timely birth dose. Next slide. And so when we look again at infants born to women with hepatitis B, so again, what are we aiming for? We're really aiming for 100% here. These are the highest risk children who really should be getting best standard of care to prevent mother-to-child transmission. And again, we see some variation, overall higher uptake of hepatitis B vaccine, which is a good thing, but still quite a few services not reaching that 100%, and some services actually alarmingly quite low, in the low 90s or even in the 80s. Anna Deng also went on and did a analysis looking at factors that were associated with birth dose uptake. And for this analysis, we're using the 7-day, the whole data set, so looking at the within 7 days. And what we saw is that it actually so people born overseas, and it's not on this slide, but women from Aboriginal and Torres Strait Islander backgrounds were more likely to get vaccine. And if you're in a public hospital or in a private hospital, you are less likely to get timely birth dose. And if you're a low weight baby, you're also, well, it wasn't as significant, but slightly less likely. And that was the reason we don't have significance there is because of the lower numbers of births in those cohorts. Now, some of this we can certainly explain. Low birth weight babies, as we know, often there's a lot going on at birth. They have to be transferred to NICU and so forth. But what we'd really be aiming for is wherever you are in Victoria, that you had the same chance of getting timely birth dose to prevent hepatitis B transmission. This is just a slide to explain the recording of hepatitis B status. So because the perinatal data set doesn't actually have a standard place to record hepatitis B diagnosis, we could look across the notification system and the VPDC and VAED and see that there was a little bit of a mismatch between women we knew were positive from the notification system and women that were positive in the database. So there's obviously some inconsistencies with recording in that area. Next slide. We were really hopeful that we could say something about immunoglobulin uptake. So the two interventions that infants should get at the time of birth are both hepatitis B birth dose if they're born to a mum with hepatitis B, but also they should get immunoglobulin. Unfortunately, there's poor recording of hepatitis B immunoglobulin in the data set, and so we couldn't actually really comment on hepatitis B immunoglobulin administration. So there were 129 doses administered to those nearly 3,500 infants. But clearly, this is actually a recording issue rather than being an administration issue. And there was evidence of local transmission of hepatitis B in terms of having 8 infants who had a notification linked to mothers. And 6 of those mothers were born overseas. 2 infants were siblings. All of them were metro, and the hospitals varied. And we don't, because again, they were all pre-2017, we've only got that birth dose within 7 days. So we don't really know if they had timely birth dose, and we don't know about HBIG. Next slide. I'm going to stop there. That's a pretty rapid transit through through the linkage study, but that's what we want to really get to the discussion at the end.
Yep. Thanks so much, Nicole. And yeah, look, some pretty amazing data there, and I'm sure it's going to be the subject of significant discussion in the panel. If anyone's got any points of clarification they wanted to make or ask any particular questions about what's just been presented, please feel free to raise your hand now or to yell out. Otherwise, we can hold the discussion for the panel. And I know that there's some questions coming through for your presentation, Nafisa, some great questions, so we'll get to that in the panel session as well. We might move straight on to the system mapping section, which is being presented by both Nafisa and Nicole. Thanks.
Great, thanks, Ben. All right, so just to kick off, so I'll be covering, we've developed 2 surveys. I'll be covering the birthing survey for the birthing hospitals, and Nicole will be talking about healthcare providers, which will explain what that's all about. But we initially conducted some consultations with healthcare providers to inform the development of the survey. So overall, we spoke to 20 healthcare providers across Victoria, and we were really just interested in around just getting that some, lived experience or practical experiences of actually what's happening on the ground level. So that we developed 2 surveys. Survey 1 was for maternity unit managers in birthing hospitals, both public and private. And the second survey was for healthcare providers working in the antenatal, postnatal care, working with pregnant women and their infants. So, and we'll be going through some of the results from that. So the birthing hospital survey was rolled out during February to March, and it was sent to public and private hospitals. And just to kind of give you a bit of a, I guess, details, the private hospitals was through the Department of Health's contact list, and the public hospitals was through the contact lists publicly available. So overall, there is 56 birthing hospitals at the time that we've developed the survey, and we've sent it to all hospitals, birthing hospitals across Victoria. So in total, 34 hospitals responded to the survey. So that's about 60% response rate. Majority were public hospitals, and most of you can see there's a good distribution between Greater of Melbourne to regional Victoria. And in terms of the people who filled out the survey, majority of them were maternity unit managers. So, and again, the surveys were asking, both influenza, pertussis, and hepatitis B care delivery. So to start with influenza, so about 50%, actually they were quite similar for both of them, about 50 to 53% had said they offer influenza and pertussis vaccination at their service. And about 49% for influenza and 32% for pertussis said that they do not. And therefore those women are referred to mostly to their GP. We were interested in where vaccinations are given. And so for the services that deliver influenza and pertussis vaccination, most of them were delivered in antenatal clinic on the same day, which is really fantastic to hear. And the vaccinations were mainly administered by midwife immunizers. So again, today we're highlighting some of the key highlights. There's a lot of data, but we're still, sort of going through it and kind of thinking about what are the critical findings here. And so some of the really interesting part we were interested in is communication. So how does a hospital know, what are the standard method of communicating that a vaccination has been given at their hospital? And what I really want to highlight is that there were, about 14 and 10 different services that relied on verbal report from the women that influenza pertussis was and influenza and pertussis vaccinations were given to women instead of conducting a standardized check or looking at healthcare recordings. And we asked a question around how does the hospital know if vaccination has been administered in the community? Again, it was similar findings where, Similar findings were, okay, it looks like my computer is fighting with me. There was a huge reliance on, actually relying on women. So verbal report from the women. And as you can see here, 25 for influenza and 30, almost 30 services say they rely verbally on the women instead of checking, say, the health records. Now, when it comes to chronic hepatitis B, just over 50% said that they do have infectious diseases at their hospital, and women mostly managed by their obstetrician or ID physician. And we asked how, if there is a standard procedure to confirm a woman's chronic hepatitis B status during admission at their hospital, and if so, how that occurs. So most answer was that obviously they check the lab results, which is great. But I just quickly wanted to highlight the third bar, if you like. So again, 11 services relied on verbal report only from the women, which is not what we want at all. So women with hepatitis B were mainly referred externally, so either to a different department or to a different hospital. Only 3 services said that they do not refer women, and therefore women are internally managed within, within their service antenatally, so they do not need to be referred to a specialist. And ideally, what we would love is that all pregnant women with hepatitis B to be managed internally, and that to be part of standard care. When it comes to protocol for seeking consent, surprisingly, 5 services said that they do not seek consent for birth dose, and 8 for HBIG prior to delivery. Again, this just really, I think for me anyway, correlates really well the data that we're getting from the community, that sort of, the discussion around vaccination or that hasn't occurred in a way that made sense to women. And maybe some of that is because it's not happening on a standard level. So some of the barriers for both HBIG and birth dose reported were that women decline vaccination. There were 3 reports of HBIG stock out, so that they did not have it within their service. And one particular service actually said that they do not routinely stock HBIG and that they need to pre-order it. So they need to know if a woman with hepatitis B is coming into their service ahead of time. And there were also some barriers reported around staff attitudes to vaccination, and also obviously transfer of baby to NICU. And my final slide is on barriers on guideline-based care delivery for mothers with hepatitis B. And the top barriers were that there were no infectious diseases specialists at their service. And this was particularly at either smaller hospitals or hospitals in regional Victoria. And also staff weren't adequately trained. There was lack of communication between services, and unclear recording of mothers' hepatitis B status. And I think most of these we've come through either through linkage or through the community study. I know I've gone through really quickly with that, but happy to take any questions if there's anything burning, or happy to save it for later on.
Thanks, Nafisa. What I might just very briefly do, so what you were just presenting there, if you could back up a slide, I'm sorry to do that to you, but so Addie from Asham has asked that, there was, in the actual community part of the survey, there was discussion about the fact that women are not always receiving adequate or correct information from healthcare providers, both on vaccination, but also hepatitis B. And do we think there are gaps in education available to the health workforce? And what recommendations would we develop from the study? I know we're going to talk about the recommendation side later, but I think some of the data that you're presenting here speak to that question. I don't know if you wanted to make any quick points about that.
Yeah, absolutely. The short answer is absolutely yes. And I know Nicole will touch on some of the barriers for in terms of education for healthcare workforce, is that there's definitely a gap. And someone put it when we were doing the consultations, is that they said, a woman goes in a truck, sorry, on a train, and she goes into a different train when she goes through the maternity services, and it almost feels like she goes into a tunnel, and you don't see her until the end of the tunnel when she's had the baby. And I think there's this sort of separation of services where always people assume someone else is looking after the mom, when in reality is women fall through the cracks. And we definitely need more resources and more training for hepatitis B care in Victoria.
Thanks so much, Nafisa. So we might actually go to, I think, Nicole's part of the presentation now, where she's going to take us through some of those healthcare provider surveys and see if that's borne out in what Nicole's presenting. Thanks, Nicole.
Oh, don't you love it when you leave yourself on mute? Right. So we've got a little bit of really, these studies were trying to look at it from different angles to get different, to sort of get some triangulation of what the data is showing and the experience. And this survey was really asking people both in hospitals and community who were looking after women through the course of their pregnancy, what was their experience. So, we sometimes do have a disconnect between what's meant to happen and what actually happens. So again, we put this out quite widely through midwife networks, through the PHNs, and we ended up with 140 recipients, which was great, mainly from public hospitals, from the hospital sector, a few from private, and then 83 responses from the community. And through the analysis, I will just sort of separate some of the community and the hospital responses, because obviously they're slightly different, and a bit of range in terms of metro and regional providers. Next slide. So this is just asking, do they provide influenza vaccine? And 74% said yes, their service did provide vaccine. So we've got community and hospital mixed in here together. So for example, most community general practices would provide influenza and pertussis vaccine as absolute standard of care. And who was it administered by? Immunisers, doctors, nurse midwives, pharmacist, and a medical student, which is good to hear. And if services didn't provide the vaccinations, they most likely referred to general practice, but also local government community centres and a pharmacy. So we asked people, how did they know that a pregnant woman has received influenza and pertussis? And in this survey, where we've got a larger number of community people, the checking air was a more common response than it was when we were asking hospitals and birthing services. But there was still quite a staggering reliance on verbal report for women. And while I'm not saying that women aren't capable of giving good verbal report, we really should be checking immunisation status, especially now. Certainly in 2021, women have been actually advised to have 4 vaccinations during their pregnancy. So we really should be actually checking what they're having and where they've had it. Next slide. We asked, how did people confirm hepatitis B status? And most said that they ordered a test. And then checking the electronic record, whether it was in hospital or in the community. So we were interested in what happened next for pregnant women with hepatitis B. And we were really sort of, again, trying to work out what happens in that setting. And so there was some referral to private specialists, general practitioners who specialise in hepatitis B, to the hospital antenatal clinic, or to specialised infectious diseases clinics in a public service. Next slide. Again, we asked about consent for administration of hepatitis B birth dose, and this is only to hospitals, so the 57 providers from hospitals, and basically reflected a very similar proportion to when we asked unit managers in terms of no birth dose wasn't always consented prior to delivery. And I think any women in the room just think really we shouldn't be asking consent of women, or actually probably everyone in the room. You know, birth is a particularly busy time, and we should be actually asking consent for both hepatitis B birth dose and for HB prior to the woman presenting for delivery. Next slide. Just if we think of the sort of cascade of care within hepatitis B, women first have to get tested, and most providers, so confidence levels 5 being very confident and 1 being not at all confident, most providers were very confident that pregnant women were offered testing, but they were less confident that women had hepatitis B viral load testing during the second trimester. And again, a bit of a distribution around how confident people were that women had access to and were prescribed antiviral therapy, and less confident again that women received ongoing care. And I think if we remember back to the woman who said they test me every pregnancy, and then they don't tell me anything. This is the kind of thing we worry about in terms of the cascade of care for women. Next slide. So barriers to hepatitis B birth dose and vaccination. So HB in orange and birth dose in blue. So again, we did get some reports of stock out. So this is from a different group of people saying that there is some vaccine stock out, which is concerning. And then women declining administration to the baby, particularly of birth dose, but also of HB. Difficult, you know, we've also then got to think, well, but are they being consented at the time of delivery as opposed to before, which would be optimal? And then some other issues like no standardised policies and procedures, a lack of clarity who's responsible for vaccine delivery, and a lack of adequate staff training. Next slide. And barriers for hepatitis B guideline-based care also were various unclear recording of status, which we saw when we looked at the linked data set. No standardised procedures, which was also reflected in the birthing surveys. Inadequate staff training was rated fairly high here among providers. No infectious diseases service, a lack of communication. Next slide. So recommendations, and at this point, I'd just like to pause and say the recommendations. We've discussed quite a lot with department colleagues, and we submitted a change to some of the Victorian perinatal data collection system in conjunction with colleagues. But some of these recommendations we've brought to groups but haven't yet been approved by the department. And we'd like to see that we really try and improve the experience of women with hepatitis B and consider peer support programs for women with Hep B. And that we need community co-design of hepatitis B health and promotion to develop culturally appropriate and co-designed pregnancy resources. There clearly needs to be some sort of standardised statewide policy for hepatitis B care delivery, because we want all women in all hospitals to have an equal chance of getting guideline-based care. And whenever we develop policies, of course, we have to consider that maternal workforce training is necessary, and that was both in the birthing survey and also in the provider survey. Maternal vaccinations being embedded in antenatal vaccination clinics, that's obviously optimal. Oh, can you just go back? Sorry, Nafisa. Optimal for women in terms of access. And reporting to AIR has recently been mandated across all services, but we also have to really think about checking of AIR in hospitals. So it's standard of practice, certainly in general practice, to check AIR prior to giving an immunisation in pregnancy, but we also want to make sure in hospital that there's a similar access to that kind of routine checking. And we need to think then, so if we've identified issues, how can we actually measure the quality improvement? So we would advocate the timely birth dose is included as an indicator, sorry about the spelling mistake, statewide strategies, because we've actually proven through this project that we can measure it. And we should be aiming for 95% of all women, and certainly 100% of women with hepatitis B. And I know 100% is always a controversial target, but this is really the highest risk children, and they should be getting the best intervention to prevent transmission. So if we have it set as an indicator in the state strategies, then we can start looking at timely birth dose and HBIG delivery being reported by birthing hospitals. We need to consider follow-up of notifications of children with hepatitis B. Reporting stock out of both HBIG and hepatitis B vaccine is important. When we originally did the survey, we thought, oh, you know, stock out, that's something that we ask when we go overseas and we're working with other countries, but actually we included it in the survey, and of course there was that as incident, you know, as incidents reported. Continuous data linkage, it's possible, and we've got other vaccine preventable infections now in pregnancy. Of course, COVID-19 is one of those, and we've also got triple elimination, which we've signed up to as a country to prevent syphilis and HIV transmission in pregnancy. And we also think that it's really important, we thank you for attending today, but that there's a chance to feedback the hospitals the finding of the study as part of their ongoing quality assurance. Okay, I think I'm done, Ben. Take it away.
Thanks so much, Nicole. What a lot in there, actually, and there's a lot for us to discuss. We don't have a huge amount of time, but there's been some great questions in the chat. What I would propose, colleagues, is that please do post more questions in the chat, and I see them starting to come thick and fast, which is awesome. Any we don't get time to address, the project team will come back to you. If you're happy to leave contact details or reach out to us, maybe we can pop our email addresses in the chat, and that the project team will get back to you with answers to any questions about the research or for your perspectives. As we open up to the panel, I'd like to make some more introductions. So we've already met May and Nafisa and Nicole, obviously. Our other panelists will be Mia Bromley, who's the Executive Director of Communicable Diseases at the Victorian Department of Health. Mia's got extensive experience across the health, education and justice systems, and has been working strongly in the community engagement space and is passionate about health and social equity. Mia's departmental colleague, Stacey Rowe. So Stacey's an infectious diseases epidemiologist, again with the Victorian Department of Health, with over 10 years experience in overseeing the surveillance and control of communicable diseases. And Stacey's really been a huge part of this research, particularly in the data linkage and system mapping studies. Also, Dr. Jack Wallace, who's a social researcher looking at the social, cultural and political impact of hepatitis B. He's a senior research officer at the Burnett Institute. And I'm really hoping you wrote this part of the bio, Jack, otherwise I'm going to be in trouble. In spite of his advanced age, he has an early career fellowship from the NHMRC. Really hoping you wrote that. And then finally, we have Naylan Akut from Liverwell, has worked in various capacities as a community organiser. At Liverwell, Naylan has worked in the health promotion team with a focus on custodial settings and also culturally diverse communities. What an amazing panel. Thanks for posting your email address there in the chat, Nafisa. I'm actually going to start. We've got some correspondence in the chat, who I'll come back to, particularly Emily and Belle from WA and New South Wales, and it'll be great to hear those perspectives too. But before we get there, I might start with you, Mia, actually. And like you're sort of obviously coming to this a little bit later in the progress. You weren't in your current role when this research was first supported by the department, and we're very grateful for the support of the Department of Health for this research. I wonder if you have any reflections on what you've heard today. And I wonder if I could ask all of our panelists to start thinking about the number one thing they would like to see happen next about improving influenza, pertussis and hepatitis B care for pregnant women in Victoria. So Mia, over to you.